Welcome back to the channel. My name's Dr. James Gill, and you joined us here to deal with my arch nemesis. We're going to deal with, no, not Bob, he'll be helping us shortly, but cardiology. Cardiology, I'm very good with the practical, but at medical school I did struggle with some of the theory. That has meant that I've got some slightly unique ways of remembering some of these bits, so hopefully they will help some of you at home get a better understanding of what's going on with that red pumpy thing inside your chest. So whilst the core of the information today has been taken from McLeod's clinical examination, McLeod's is very much a full fat meal. There's a lot of work involved with it, and sometimes on the wards you want something a little bit trimmer. So we've got a copy of Clinical Examination Essentials from Student Consult here today that we're going to give away. So wait until the end of the video and we'll tell you how you can perhaps get your hands on one of these smaller, concise textbooks. So, if we're going to deal with murmurs, I suppose the first thing we need to do is find out what actually is a murmur. Well, when blood is passing through, well, actually let's move away from blood for a second. Let's do straightforward physics. When you have a tube and fluid, air, something is moving or flowing down that tube, as long as we have laminar flow, so always going forwards, we tend to get relatively little noise, a whooshing if anything. So it's the same as cars going by you on a road, whoosh, whoosh, whoosh. However, if we put something in that tube, for example, from cardiology, if we were to put a plaque there, for example, or maybe thicken the valve so that we no longer get this uninterrupted laminar flow, we get turbulent flow, then we'll hear, we get extra noises here. It's the same as if on the road there's a sudden speed bump that everyone has to go over. It changes the pattern of the fluid dynamics, so we're getting extra noises. And that's what we're going to be looking at with cardiology murmurs, where something has affected the flow of the blood over the heart valve and thus changed the sound of the flow, or perhaps the sound of the valve closing. So that's what a murmur is, but it looks like there's still a lot for us to unpack there, particularly if we're going to talk about heart valves opening and closing. So there are four valves in the heart. We've got the aortic valve, the pulmonary valve, the mitral valve, and the tricuspid valve. So if we just do a quick tour of the heart, blood comes in from the atrium through the tricuspid valve and will be ejected from the right ventricle out through the pulmonary valve. Blood will then re-enter into the left atrium from the lungs, and it'll pass from the left atrium through the mitral valve into the ventricle. The left ventricle will then inject that blood up through the aortic valve and then out to the body. And when it comes to clinically examining the chest or the precordium, we're going to listen to those heart valves in the following order: aortic, pulmonary, tricuspid, and mitral. And some people will use the mnemonic apes to man as the mnemonic to remember APTM. So in terms of auscultation of the precordium, we need to listen to the aortic region, which is the right upper sternal border. We need to listen to the pulmonary region, which is the left upper sternal border. We want to listen to the tricuspid region, which is the left lower sternal border. And then we also want to cover over the apex beat, which is going to be over the fifth intercostal space mid-clavicular line. So that clinical examination order over the aortic area, the pulmonary area, the tricuspid area, and the mitral areas are different both from the order of the closure of the valves and also the positions of the heart valves in the actual organ itself. So why are we listening in these odd locations? Well, we're going to go back to that concept of murmurs, turbulent or laminar flow, and it's all about sound, which is why cardiology is, big stethoscope type medicine. With the aortic, pulmonary, tricuspid and mitral areas of auscultation, because that's the crucial bit, we're listening to the direction in which the sound goes. So the aortic valve auscultation region is actually going to be quite far displaced from the anatomical location of the valve, because we're talking about sound propagation within the body. Similarly, that's why with an aortic stenosis murmur, the sound will propagate up the carotid artery, so we'll get radiation of that murmur to the carotids. Okay, so that touches on some of the weird and wonderfulness that we are going to be explaining. I suppose we need to look at the order of the heart sounds. Now, our classic lub-dub, lub-dub, lub-dub. So that's lub is actually called the S1 heart sound, and dub is the S2. So the S1 sound, or our lub noise, this is the ventricular systole, and it's heard when the AV valves, or the mitral and tricuspid valves, close. At the same time, the aortic and pulmonary, the semilunar valves, will open, but that's not going to give us a noise in the vast majority of cases. Our dub noise is when the aortic and pulmonary, our semilunar valves, close, and by comparison, the tricuspid and mitral, our AV valves, open. Now, I'm a very visual chap, and when I was younger I spent a lot of time building computers, and I was always bothered about the graphics card. I'm a big GeForce fan, NVIDIA all the way. However, didn't really give a monkey's about the sound card, and I was quite happy to have the cheapest one. I'm just not an audiophile, I'm not wired that way. And that's probably one of the reasons why I struggled to get my ear in, as it were, with cardiac murmurs. So there's a simple way that you can help yourself with that at the beginning of your examination by feeling the radial, or carotid if you wish, pulse. Every time you're feeling a pulse there, that's obviously ventricular contraction, ventricular systole, and that's when the AV valves, the mitral and tricuspid, are closing, and we know when we can't feel the pulse, but we're hearing the dub on the chest, that's our S2, and that's when the semilunar valves, the aortic and pulmonary valves, are closing. So with that, we know that when we can feel the pulse, what we're going to be hearing is our S1 sounds, so our tricuspid and mitral valve sounds. So that should help guide us much more in our examination findings with regard to what we're hearing. So we've got 4 heart valve pathologies that we're going to talk about. Let's start off with what I feel is the easiest, aortic stenosis. So this is quite a comparatively common murmur, and it's very easy to hear on the chest. Possibly one of the reasons why it's so common and easy to hear is actually one of the causative factors of aortic stenosis is age. You know, it can be picked up in people as young as 40 and 50, and it's just that valve is becoming calcified or thickened, and it's just used to being, well, used so much. Now, in terms of our classifications, we say that this is an ejection systolic murmur. So what that means is we're getting the S1 sound and it's coming afterwards. So we'll change from having our lub-dub to lub sound. And actually what we're going to find with aortic stenosis, because it narrows this area for blood to be ejected from the heart, it's very much like putting your finger over a hose pipe. You've got a nice wide bore of fluid coming out of the hose pipe. You put your thumb over it, it becomes much sharper, much higher note. So we now get, rather than lub-dub, we get lub-whoosh, lub-whoosh, lub-whoosh. And that's what you're going to hear when you listen over the aortic region. You'll hear very classic lub-whoosh, lub-whoosh, lub-whoosh. But if you're not absolutely certain, as we say, certain murmurs have certain radiations, so we can confirm what we're hearing by, with an aortic stenosis, that whoosh noise will radiate up the carotids. So by getting the patient to hold their breath, if we can put the stethoscope on the neck and listen over the carotid, where we should hear the same whoosh, whoosh, whoosh noise going up that carotid because it's simply being transmitted in that tube of fluid or tube of blood. Now, we've mentioned that age is going to be a prime causer of aortic stenosis, but there's a couple of other things that we might see as well. So we may find an aortic stenotic murmur in cardiomyopathy, where we've got changes to the actual tissue of the heart. We may, however, see that same noise, lub whoosh, in sepsis. So with sepsis, obviously the heart is going 10 to the dozen, and that's where we're getting a flow murmur. I actually have a flow murmur myself. So when teaching the students, if I go for a run up the stairs, I can get my heart rate up, and that will allow them to hear this non-pathological, benign whooshing noise in my chest, which, because it's a left-sided valvular pathologies, if I breathe out, we actually get an increased volume to that. But this flow murmur is entirely benign, and it's simply because I like to think, certainly pre-lockdown, I was relatively fit. So we know that if we can feel the pulse, that's S1. We know that we've got an ejection systolic murmur, so coming after the S1. We know that an aortic stenosis is going to radiate to the carotids, and it's going to be louder in expiration. And we know that it's going to make a whoosh noise. However, that's an awful lot to remember. When you're doing a cardiovascular history, as with any history, don't forget that about 80–90% of your diagnosis is going to come from your history, and patients with aortic stenosis tend to be sad. Now, I don't mean that they're unhappy. What I mean is that they're likely going to have syncope, they're likely going to have angina, and they're likely going to have dyspnea, shortness of breath as well. So if they've got those three things, that's automatically going to start me thinking, am I going to find aortic stenosis when I listen to this patient's chest? Now, small clarification with that syncope, that's exercise induced. So they try and do exercise and they feel lightheaded and or collapse. This is not a collapse after they've done exercise. Now, I've said that aortic stenosis is relatively common, so unsurprisingly, there's quite a few famous people that have had aortic stenosis. One of those is Arnold Schwarzenegger, we think, and it's very interesting if you have a look at the procedure that he had with his valvular pathology. So he had what's called a Ross procedure. So if we're going to start off by having a look at the heart itself, we can see the pulmonary valve is tricuspid, as is the aortic valve. This is why Arnold Schwarzenegger was able to have a Ross procedure where his healthy pulmonary valve was removed and was used to replace his diseased aortic valve with a cadaveric valve replacing his previously healthy pulmonary valve. One of the main reasons being for this choice is that he wanted to be able to continue to exercise and act and generally be Arnold Schwarzenegger, which would have been much more difficult if he'd had a metal prosthetic valve. Now, talking about a metal prosthetic valve is a wonderful little segue there, because when we're listening to murmurs, we need to grade them. So we can have a grade 1 murmur, which is basically a professor of cardiology is going to struggle, but will be able to hear it. All the way through to a grade 6 murmur, where a medical student will be able to hear it at the end of the bed, get this, without even using a stethoscope. And that is most likely what we would see if someone had a metallic valve. Often you'll hear that coming from the end of the bed as you're talking to the patient, because you're hearing that valve open and snap close, open and snap closed. So that pretty much wraps up our aortic stenosis. Let's stay with the aortic valve and move on to aortic regurgitation. So if we just think about that, if we think about regurgitation, we're going to bring back, a lot of people associate the word regurgitation with vomiting. You could regurgitate up food. It's not quite the same thing, but nevertheless that's where we have that mental image. That's important to keep in mind, because when we're talking about regurgitation of flow of blood, we're talking about blood going through the valve the wrong way. So this is a diastolic murmur. So we're going to hear this before the S1 sound and after the S2. So we'll have noise, lub, dub. Noise, lub, dub. So a health warning here, I'm being a little bit tenuous, but again, bear with my mind. So if we're going to think on a Jurassic Park-esque theme, a raptor could have regurgitation, and that's important because the sound that we hear with aortic stenosis, we have a whooshing noise. With aortic regurgitation, we're getting a rrr, 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 a rolling of the R noise. So we'll have lub, dub, rrr, lub, dub, rrr, lub, dub, rrr, lub, dub, rrr. Yes, I know these things are weird, but trust me, it works. And you'll think I'm being completely daft, and you'll listen to somebody's chest and you'll think, hold on, regurgitation, raptors, roaring. I've got it, it's aortic regurgitation. Again, very visual person, and these are the ways that things stuck in my head when I did this revision. So where are we going to hear this diastolic rolling of the R? Well, it's loudest over the apex of the heart down here. So thinking about that, we've got a different location, even though we've said we are listening classically to the aortic valve over the second intercostal space by the right sternal edge. Now, this highlights what we're thinking about with blood flow. So with aortic stenosis, we've got flow radiating out and up to the carotids. With regurgitation, we've got flow going the wrong way, so now radiating down toward the apex. So potential causes of aortic regurgitation could be infective endocarditis, something that's directly affecting the valve, or possibly a connective tissue disorder such as Marfan's disease, where everything is not quite as tight as it should be. So if we're thinking that the valve closes but can't hold valve because essentially it's a bit floppy, or the ring that holds the valve in place is extended a bit, again because things are floppy, you can see how that might regurgitate through. So if we want to talk about famous people with Marfan's, Marfan's is classically someone who's quite tall, thin, will have a high arched palate and can have an arm span greater than their height. And a chap who'd be very familiar to a lot of Americans who would be tall, thin and very famous was Abraham Lincoln, who was thought to have Marfan's. So would have been at risk from aortic regurgitation. Another very famous person, but someone we don't have quite the same direct connection to, who was thought to have Marfan's, was Julius Caesar. So there you go, there's something for your pub quiz when the world reopens after COVID. So let's move to the other side of the heart. So we've gone from aortic pathologies to mitral pathologies, and let's return to our stenosis. So with mitral stenosis, in contrast to the aortic stenosis, here we have a mid-diastolic murmur, whereas our aortic stenosis was a systolic murmur. What that essentially means is a mid-diastolic murmur, we're going to get it between our lub and our dub noise. So we can actually sometimes hear our S1, our lub noise, increase in volume as an extra hint to help us get our ears tuned into what we're listening to. Now, I don't have a good thing to listen to or a good sound like our aortic stenosis whoosh or our aortic regurgitation rrrs. However, what we do have is a Simon and Garfunkel murmur. I'm sorry, what? A Simon and Garfunkel murmur? Have I gone completely tapped in the head? Well, yes, but no. So one of the things that you don't hear with a mid-diastolic murmur, a mitral stenosis, is the sound of silence.
Within the sound of silence.
So we don't have that lub, silence, dub, lub, silence, dub, as we would expect. Instead, we're getting lub, dub, lub, dub, lub, dub, lub, dub. That middle emptiness has now been filled by this turbulent flow. Now this mitral stenosis may cause this snap and increased volume on our S1 because of the changes to the valve there. So we may actually get lub, dub, lub, dub, lub, dub. We get that increased prominence for our S1. Now, there's not really any radiations with mitral stenosis. However, we do have a classic position where we're going to listen to it, and that's over the apex. And for your clinical examinations, this is where we'd expect to change the stethoscope from the diaphragm to the bell and roll the patient over. So when it comes to auscultating murmurs of mitral stenosis, we want to flip over to using the bell, or rotate the stethoscope over, roll the patient over into the left lateral position, and again we're going to listen 5th intercostal space, mid-clavicular line. Now, whilst there might not be any radiation to help us, we may see other changes to the patient, and they may have a malar flush, so reddening over the cheeks, and this is due to increased levels of CO2, because rather than blood going out where it should do, that blood goes out but then comes back into the heart because of that regurgitation. Our causes of mitral stenosis are again going to be infective endocarditis because we've got things growing on the valve there, but we can also see it in autoimmune conditions such as rheumatoid arthritis, and in a particularly classic case for medical school, but in a rather unfortunately rare scenario, we can get mitral stenosis due to what's called an atrial myxoma, where you've got a small tumour inside the atria, which will give a classic plop noise when you're listening to the S1 and S2. So you may end up with lub plop dub, lub plop dub. Unfortunately, it's something I've never heard on the wards before, but one day I hope to hear it myself, just because it's one of those defining things about medical school. I mean, we've talked about endocarditis as several potential causes for these valve issues. Realistically, most doctors will never come across a lot of the pathological features of endocarditis, but I'm not sure if the word is pleased, but I can say that I have seen a case of endocarditis with the classic medical school features of splinter hemorrhages, Osler's nodes and Janeway lesions. And when we diagnosed that chap, subsequently it felt that most junior doctors in the hospital, obviously asking his permission, came to see if they could have a listen to his heart and to look at his fingers. So I put that atrial myxoma in that list of things that I would like to clinically tick off my formal education list, if you will. So one of the other causes of mitral stenosis is rheumatic fever. That's where it's very rare now because we have antibiotics, but it was classically seen where an untreated streptococcal throat would then cause an autoimmune reaction, damaging the heart valve. Now, Bill Paxton, staying with the idea of trying to talk about famous people with valve issues, he is thought to have had mitral stenosis because he did have rheumatic fever as a child, and he went for heart valve surgery. Unfortunately died from a post-operative complication, but a regrettable story, but we've still got somebody that we can pin our mental hats on there to envisage a person with it. So in terms of those famous people so far, we've got Arnold Schwarzenegger with his aortic stenosis, we've got Abraham Lincoln with his aortic regurgitation, and we've got Bill Paxton with his mitral stenosis. But yes, it does feel like I'm scraping the barrel, but again, I'm a visual guy and I need other ways of hooking this information in my brain. Okay, so final 4 of the major murmurs. So we're now going to do mitral regurgitation. So again, as we've seen before, we're going to flip this. So with aortic regurgitation, we had a diastolic murmur. With mitral regurgitation, we've got a systolic murmur. But it's not just a systolic murmur, it's a pansystolic murmur. So you're going to hear it right the way across our S1 all the way up to the S2 sound. So with mitral stenosis, we're going to get our lub-dub changed more to a lub-de-dur, lub-de-dur, lub-de-der. Again, that S1 is going to be much louder, hence the lub-de-der, lub-de-der. These are much more granular ways of, well, certainly reproducing the murmurs, but again, it lets me feel the murmur with my mouth by making the noises. So again, helping me to keep those in my head. So really pushing the barrel out with our noises when it comes to mitral regurgitation. It's a very cold murmur. Yes, I'm doing another tenuous link. That's because the sound that we're classically going to hear with a mitral regurgitation is, with it being pan-systolic, we're not getting our lub and our dub noises anymore. We're more likely going to get brr, 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 right the way through our both sounds, replacing it with just one long noise. Brr, brr. Unlike mitral stenosis, where there wasn't any good radiation, this time with mitral regurgitation, we listen over the apex, but we're going to hear the sound radiating up into the axilla. So we've got a little bit more physical evidence to support our murmur diagnosis here. And unlike mitral stenosis, we're still going to be using the diaphragm over this region. We can, however, force that brr noise to increase in volume by getting the patient to squat down, increasing the intrathoracic pressure. Another way that we can do that is with the Valsalva maneuver, so getting the patient to take their thumb and essentially blow on it. In doing so, it increases the thoracic pressure, and we're going to get an increased cardiac return, so we're going to get an increased flow of blood over that stenotic valve, increasing that brr, brr, brr noise. In the same way that aortic regurgitation could be as a result of Marfan's, again, we've got another regurgitation, so Marfan's is another reasonable suggestion. But there's perhaps a couple of other things that are more clinically relevant. So heart valve replacement of the mitral valve can end up causing mitral stenosis. We can have problems where we've actually got catastrophic damage in the heart. One of the possible causes of a mitral valve regurgitation is Dressler syndrome, which is after a myocardial infarction where damage to the heart muscle causes rupture of these papillary muscles, allowing the valve to flip the wrong way round, allowing regurgitation. And yet again, there's also infective endocarditis as another possible cause. But that tends to be only in the most acute phase. So that pretty much wraps up our murmurs overview. So just to make sure we've got that tactile nature of the sound again. So aortic stenosis, we've got an ejection systolic murmur going whoosh. With our aortic regurgitation, we've got the raptors prowling around going lub dub rrr, lub dub rrr, lub dub rrr, lub dub rrr. With our mitral regurgitation, we've got a mid-diastolic murmur, giving us an absence of silence, so Simon and Garfunkel murmur. And finally, we've got our mitral regurgitation, so giving us a complete loss of S1 and S2 for a pan-systolic murmur, brr, 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 right the way through. I don't mind making a fool of myself if it helps the students remember these things, and I think that's the crucial thing here. These videos are for yourselves to help improve your knowledge. In terms of simple ways of remembering things, aortic stenosis, you are sad if you've got aortic stenosis, i.e. you've got syncope, angina and dyspnea. By comparison, in the history of a patient with aortic regurgitation, doesn't work quite so well, so we say they has regurgitation, slightly butchering the English language there, because a patient may complain of features of heart failure, so shortness of breath, swelling to the ankles, difficulty with fatigue. They may have angina and shortness of breath, so the patient has aortic regurgitation. with mitral stenosis. Chaps get mitral stenosis, so the patient may present with a cough, again features of heart failure, angina, palpitations and possibly shortness of breath. To complete our quartet, mitral regurgitation, again I'm really straining here, but you get a high definition pie with mitral regurgitation. Again, heart failure or possibly fatigue, dyspnea, and you'll also have palpitations, and as mentioned, one of the main causes here, they may have had or tell you about previous infective endocarditis. Okay, well, I think that's probably a good opportunity to bring things to a close before it gets even dafter. So if you want a chance to win Clinical Examination Essentials, please like the video, make sure you've subscribed to us here and drop us a comment down below. This has been a slightly different approach in terms of teaching styles. So tell me what you thought went well and what you thought we could improve on this video, and we'll enter you a raffle to try and win this copy to you. And yes, we'll post it worldwide. On that note, take care, have a good one. I'll see you guys around. Cheerio.